So let's take a look at the DSM and see what the DSM tells us about the anxiety disorders. So in the library homepage, in the A to Z databases under the letter P, I will scroll down and I will go to Psychiatry Online. And remember, it wants you to use Firefox, ideally with this particular tool and search engine, and that is something that I encourage. I would suggest that once you get into the Psychiatry Online, and of course my password has been placed in here, you will scroll down to the DSM-5, the Statistical Manual, the Diagnostic and Statistical Manual of Mental Disorders. The 5th edition is the edition we're using now. When you click on this, you will then be brought into the full manual. And you can see here we have full access to the manual, and you will go down to, and you can scroll section 1 and read the basics. I'm going into section 2, and I'm going into the diagnostic criteria and codes. You can see how all of the various disorders are divided in the diagnostic statistic manual. I will go to anxiety disorder, and I will click on anxiety disorder, and I have a rich database of information here available to me. So that is how we get into the DSM, and now let's look at the anxiety disorders themselves. So under the separation anxiety disorder, you're given a very clear diagnostic criteria. So for example here, that the criteria for the separation anxiety disorder is developmentally inappropriate and excessive fear and anxiety concerning separation from those to whom the individual is attached, as evidenced by at least 3 of the following. And so you have 8 criteria here: recurrent excessive distress when anticipating or experiencing separation from home or from major attachment figures, persistent and excessive worry about losing major attachment figures or about possible harm to them, such as illness, injury, disaster, or death, persistent or excessive worry about experiencing an untoward event, so getting lost, being kidnapped, having an accident, becoming ill, that causes separation from a major attachment figure, persistent reluctance or refusal to go out, away from home, to school, to work, or elsewhere because of fear of separation, persistent or excessive fear or reluctance about being alone without being attached to the figure at home and in other settings, and persistence, reluctance, or refusal to sleep away from home or to go to sleep without being near a major attachment figure, repeated nightmares involving the theme of separation, and repeated complaints of physical symptoms such as headaches, stomach aches, nausea, or vomiting when separated from a major attachment figure, or this is anticipated to be happening. Second criteria would be to fear and anxiety or avoidance persistent, lasting at least 4 weeks in children and typically 6 months or more in adults. The disturbance causes clinically significant distress or impairment in social, academic, occupational, other important areas of functioning, and that's really important. And the disturbance is obviously not better explained by another mental disorder, such as refusing to leave home because of excessive resistance to change in the autism spectrum disorder, delusions or hallucinations concerning separation, refusal to go outside without a trusted companion and agoraphobia, or worries about ill health or other harm being significant, or then, of course, generalized anxiety and other conditions. The next part of the DSM, and this is consistent throughout, you get some diagnostic features of the disorder. So, you talk about excessive worrying and separation from home, some details of how that worrying might look, what those criterion might be exampled as having. And this is really important because this really provides you with a very rich experience of what that separation might look like. So I want you to take some time to go through the diagnostic features of each of the disorders that I'm presenting you today and read the DSM, and you will have a more detailed example of each. I'm not going to spend the time reading them to you. Each section provides you with an associated feature and supporting diagnosis. So, for example, it provides you about how it might look, how somebody might present, what some of the worries might be depending on their age. And then it moves into prevalence. So for example, with separation anxiety disorder, you can see that in children 6 to 12 months, prevalence is estimated at approximately 4% of the children. And in the United States, the 12 months prevalence is 1.6%. So you can sort of get some statistics there. We talked earlier last week about development in course, and you can see here how and when these develop. So in this particular case, you might see something development around the age year of 1 when infants may suffer from stranger anxiety. And then you get into section here on risk and prognostic factors like environmental risks, the genetic and psychological risks, the cultural related diagnostic issues, gender-related diagnostic issues, section on suicide risks, and in this case, separation anxiety in children may be associated with an increased risk of suicide. So that's something to really pay attention to. Functional consequences of separation anxiety. So, for example, avoiding school, camp, and adolescence might leave that person in a situation where they are limited in their independent activities. And then there's a differential diagnosis section for each of the disorders, talking about how it may not be separation if it is, in this case, other disorders. And then there's a rich resource section. So again, if you are interested in doing an assignment or doing a project on separation anxiety disorder, using the DSM as your primary source to provide your example, and then delving further into other references and sources would be excellent as well. And then it moves into the next section. So selective mutism, again, it provides you a full diagnostic criteria, and then moves into the same pattern, working its way through prevalence and development and course and prognostic factors and risk factors. So again, I'm not going to read these aloud to you. The language is very accessible. I expect that you would go through each of these. You can then look at the specific phobias and see how these are outlined. So for example, the specific phobias are marked fear and anxiety about an object or situation like flying, heights, animals, receiving injections, seeing blood. And then in the criteria is more clearly defined. So take some time this week to explore the anxiety disorders, learn about each, use the DSM, and that will give you a good launch to each week's course content. And the DSM through our library is fantastic. And so for this week, take your time, learn about the anxiety disorders, read each section, and learn about each so that you can become familiar with the kinds of anxiety disorders that you will see when you are working with children and youth in the settings that children and youth practitioners work in. So let's end our PowerPoint here by looking a little bit at how these disorders come to be. So if we say from the current slide, the anxiety disorders come to us equally or as a combination of biological contributions. In this particular case, we don't necessarily inherit the anxiety disorders themselves, but we do inherit the vulnerabilities to anxiety and panic. And stress and life circumstances that generally can activate the underlying vulnerability that we have. So there are biological causes, and we do inherit vulnerabilities, and these are biological causes that have to do with our brain circuits, our neurotransmitters, GABA, the noradrenergic and serotonergic systems. And these are the main neurochemicals that inhibit our anxiety and panic and fear experiences. And so that's really important to look at as well. The psychological contributions, obviously, our thinking began with Freud in terms of anxiety being a reaction to danger, and anxiety involves reactions of an infantile fear situation. So that's early thinking. Our behavioristic views look at anxiety as a result of direct classical and operant conditioning and modeling, meaning that we learned our fears, they were modeled to us, and they were reinforced. The psychological views really, again, link back to Freud, and not necessarily to Freud in terms of our understanding, but our beginning on a thought around early experiences and uncontrollability and unpredictability. The social contributions to anxiety and fear are really around stress and stressful events that trigger the biological and psychological vulnerabilities, meaning stressful events trigger the underlying vulnerability we may have in the way our brain functions and our neurochemicals and how they respond. And reality is that many of these stressors tend to be family and interpersonal stressors that then trigger the biological and psychological vulnerabilities. But when we look at an integrated model of anxiety, we must really look at the biological vulnerability that intersects with the intersection with the psychological and experiential and social variables that produce the anxiety disorder, meaning it's our thinking and our experiences and the way our brains work and function. And this is really consistent with the idea that stress contributes and triggers anxiety for those who are vulnerable to pervasive anxiety. Comorbidity, the idea that the anxiety disorders can exist across the disorders or comorbidity that exists, here's what it is. Half patients of people with anxiety have 2 or more secondary diagnoses. For many people with anxiety disorder, major depression is the most common secondary diagnosis. And comorbidity suggests that there's common factors across all of these anxiety disorders, and that there is a relationship between anxiety and depression. So when we summarize the anxiety-related disorders, these are the largest domain of psychopathologies that exist, and I would be very concerned around how much persistent and pervasive anxiety we are seeing. From normal to disordered experience of anxiety, you must consider the biological, psychological, the experience or experiential and social factors. Fear and anxiety persist, and our cues are here to help remind us when we are afraid. But when people are avoiding or having symptoms of avoidance that cause significant distress and impairment, that's when fear and anxiety become disordered. Psychological treatments are generally superior in the long run. Most treatments differ from anxiety disorders and involve similar components, a cognitive behavioral approach to treatment. And the treatments that we use suggest that anxiety-related disorders share common processes.